and I'm about to introduce our first speaker, our first keynote speaker, and I'm very pleased that we were able to get Dr. Sabine Kapasi to speak with us today. Welcome, Sabine. I understand you've just stepped off a plane, so I'm very flattered that you've been able to squeeze us into your busy program. I won't embarrass you by asking you how many countries you've been to in the last month, but I think we appreciate that your work with the United Nations is highly involved, which is why we're so pleased that we're able to bring you to API Days India.
Right.
Okay. So, can you hear me all right? So we will be able to share your we will be able to share your slides for you. You just need to give us a signal like next slide.
I've been trying to upload them, but thank you so much for that. So first of all, John, thank you so much for having me. I'm sure a lot of you have joined from different parts of the world. So good morning, good afternoon, good evening, whichever part of the world you are coming from. And sorry, I'm going to go very harsh to begin with. So can you please go to the next slide? Right. So, from March 2021 or July 2021, almost 89,000 people in India are recorded to have died from oxygen crisis, not from other COVID complications, but from oxygen crisis only. And believe me, these are official numbers. We have suspected actual numbers to be times these numbers, right? Quite recently, in Gorakhpur, 60 children died in Baba Ramdev Hospital in a week because oxygen supply was not pre-ordered in a regulatory manner that is needed by the hospital rules. Can I the next slide, please? 1.7 million people in India die due to heart attack and due to stroke-related deaths every year. This mark is going to cross 23 million in 2030, and we are counting from beyond the 2000s, right? One person every 4 hours, even in the US, is dying due to stroke. And rural people die more because of NCDs, be it cardiac arrest or stroke, than the urban population. Can I get the next slide, please? In the Saleh region, MMR is 597 out of 1 lakh women. What is MMR, you might ask? It's maternal mortality, the basic understanding of development of any geographical region. This is 597. Saleh is a region in western part of Africa which constitutes around 8 quite diverse, quite interesting nations. In Chad and in South Sudan itself, more than 1,100 women die because of childbirth every 2 months. And the global average is still, after so many developments in healthcare, 338. And the most heart-wrenching part of it is 80% of these deaths are preventable deaths. Can I have the next slide, please? In India, people have talked about India needing more development than others. I believe India is doing very, very well in terms of digital integration in healthcare, and quite a few other areas where tech integration has actually succeeded, whereas not in other much more mature economies. But in India, third most common cause of death of children under 5 years of age is still dysentery. Do you know cure for dysentery? And ORS, a mixture of oral rehydration solutes that That is it. That's simple. Kid, sugar and salt is what can save you. And still, 30,000 people die every year in India. 30,000 children die every year in India only because of dysentery and diarrhea. This incidence, of course, is still prevalent in adults as well, as in 15% of adults die because they go to the hospital far later than they should, and they believe that these problems can be avoided. Can I have the next slide, please? So, let us kind of break down. The reason why I've been bombarding you with these facts is not to overwhelm you or tell you that our healthcare system is beyond saving, but to understand what are the core problems of the system. So, if you can look at this in a slight more detail, let me just expand upon it. The core problem of healthcare is that the healthcare system exists today in silos. And this is not just true for India, this is true for countries across the world, where hospitals, insurances, diagnostic centers, single doctor clinics, all of this, and health recording systems, EMRs, everything exists in silos, right? So, what is the reason why that happens? Because care is expensive. We have not been able to create solutions to still bring down care for more than 60% of the people. Would you believe it when I say that 60% of the global population still spends more than 1 month of their salary to have one single visit to a doctor? One single visit. And you might as well believe it because this is the IMF numbers, right? There's lack of awareness, of course, not just among the public, about the health seekers, but also among a lot of health providers. Can I please have the previous slide for a second? Yeah, there is a lot of overburdening in the system. There is conflict of interest, of course. There is, and there is lack of due diligence, to be very honest. There is misdiagnosis and lack of access as well. And what happens because of this? There is high mortality, high morbidity, and there is poor quality of health overall. Health outcomes get affected, and that affects economies. That affects economies. Can I have the next slide, please? So, what is healthcare access? As I mentioned, that 64% of the countries less than one doctor per thousand individuals, and India, don't ask, we have much lesser than that. More than half of the world's population, still does not have essential services that they need in terms of healthcare. Now, can I have the next slide, please? May I please have the next slide? Yes. So, my previous slide did mention about unregistered doctors, unqualified doctors, and lack of specialists. And now let me talk a little bit in detail about affordability. So, why do we talk about affordability in care? Because in India, or rather across the world, the middle class has shrunk in the last 2 years. And how? Last 2 years have grossly affected the middle class, which is now not more than 10% of the global populace. And we belong to a privileged class, a controlling class, and we underestimate the lack of access that people face when there are resources to even invest in personal care, personal health, right? And average Indian ends up spending $32.6, right, for a single government healthcare program, which is of course double what the US spends. But also, you have to keep in mind that in India, $32.6 is a 1 week salary, and private infrastructure constitutes 70%. So out of pocket expenditure, because insurance coverage is what, 18%, it across the board, and across the global in the global statistics, health insurance coverage is merely 12%, right? So a lot of expenditure is still out of pocket. Can I please have the next slide? May I please have the next slide? Yeah. So the let us for a second also unpack the problem of the quality of care. right? So in India, only 8% hospitals are NA certified. So NABH is the basic accreditation board for hospital certification, right? And again, sorry, my bad. 8% hospitals are under process and only 1% are certified. So if you even make it to a hospital and you realize that the doctor is underqualified or maybe sometimes not qualified at all, your hospital is far under equipped to handle you or handle your care, and there is no due diligence. You cannot report to anyone because anyway the government and the regulatory bodies have said that these hospitals are not certified. So what happens then? You don't have insurance, out of pocket is extreme, out of pocket expenditure is extreme. We have convoluted referral networks between sorry, I've been thinking about slides, so I've been talking about it as well. No, but there are convoluted referral networks between doctors, investigative agents, as in the labs and any other investigative bodies, as well as hospitals themselves. So doctors is a separate entity here because a lot of these centers are standalone clinics with single doctor entity in them, right? So these are different silos that exist, and if you look at it from the financial perspective, all of them benefit from the patient coming to them and from the patient being sicker, getting sicker, and staying sicker or staying sick. Sorry, please excuse me that. Can I have the next slide, please?
Hi, Sabine.
Please have the next slide.
Just quick moment. The audio connection isn't so good, so we think maybe it would be better if you switched off your camera so that you can use the available bandwidth for the best audio quality. Because we want to make sure that you get your point across as well as
Yeah,
possible.
do you mind if I share my own slides because I think they have uploaded now?
They're uploaded, are they? Okay. Well,
Yes.
let's try that for a moment. Can we do that,
Yeah,
team?
I think that should help.
You can bring up
So,
Sabine's
while
slides.
my slides are, yeah,
So
well,
you have control of your slides now, which will be
yes, I do.
smoother. But
I
also,
do.
I think
Thank you.
maybe the internet
I'm trying to
connection.
change the network, yes. I'm changing the network, sure. So, while I am in the process of changing my network, I would also like to mention that 5 million people die every year. That is almost, and almost all of them in India, due to inadequate healthcare services, right? So these are the people who die because, not because the healthcare services did not exist, or not because the knowledge does not exist or the information does not exist, but just because access is so less. Now just think for a second and imagine the number: 1.6 million people every year. So Indian healthcare setup makes 5.2 million medical errors every year. You might find these numbers staggering because India does not even have a very robust area network for that matter. And still, if you look at it, you might not find this very surprising because in India, less than 2,638 medical negligence cases have been reported. So you understand the power dynamics here. Now, the reason why today, in a talk where we are talking about technology and technological integration, the reason why we are talking about these problems is here. What are the solutions? So the solution, excuse my slide, but the solutions are technology based. So advanced technology which can actually integrate a lot of the solutions can result in plugging the gaps and connecting these silos of control, which is doctors, hospitals, centers, insurances, government relations, and government programs, of course. So, what does, in my understanding, digital transformation in healthcare look like? So, if you look at the digital transformation, it is not just about one area of healthcare. You first need to look at health data, which is very, very important, where you really need to integrate a lot of EMRs, electronic medical records, into one place, create a repository of historical health data, which can build intelligence towards preventive outcomes. Now, please mark that I'm talking about preventive outcomes, but this is not about predictive care. The reason why this is not about predictive care is because we are still not, as a system, intelligent enough to predict an event of care depreciation before it happens. This, of course, is, let's say, next step ahead, or aspiration for everyone, including people like me who have been spending most of their life in improving public health systems. But we are at a place definitely where we can identify problems at an early stage and we can solve them very soon and effectively, so that not only the cost of care is reduced in lifetime of care, but the cost of economic burden to the system is also reduced, and the sanctity of the system is restored, both in terms of lifespan as well as in terms of efficacy of healthcare systems. That is one. So, what should we do? Reducing cost is primary. Primarily, we need to reduce cost. How do we do that? Right? So, let me first go through what do we need to do, and then I'll talk about how can we do it. Second is optimizing workflow. Right? We need to make sure that we have optimized workflow in terms of good doctors, in terms of good data in testing facilities, and good diagnostic outcomes and good decision making systems. We need to have systems, and when we talk about responsive, we are talking about fast PAs, insurances, and regulated health program that are very effective and efficacious in building networks to solve not just current health crisis, also NCDs and larger health programs, all at the same time, while being sensitive to the needs of people at large, because health, believe it or not, is both global as well as extremely culturally sensitive and local, right? Data suggests that 2,000 people, the community size that is considered in any health crisis or any health problem. And last but not the least, of course, data security, because this is private data, which is quite often government held and government sponsored. So the security of this data is paramount. Now, how do we go about this? So, first of all, of course, we need to document the segregation, right? We need to index and scan the EMR. So, I have been speaking about EMRs for the last 2-3 minutes, of course. The reason why I've been stressing so hard about it is, at least in India, less than 2% of health records are digitized today, right? And again, this is an overestimation because we don't even regulate much of our healthcare systems. So there is so much more out there. So the number might as well be much lesser than 2%. Right now, we need to scan these. We need to index this, and we need to kind of create a data repository of health intelligence, which is based on historical data, which we haven't done aggressively. Tamil Nadu, which is one of the southern states in the country, has been very aggressive in trying out current health programs, which actually improve capturing of data which is current in nature. So suppose if you go to the doctor right now, your data might be digitized, but what happens to your data which was collected 2 years ago, 5 years ago, 2 years ago? I am a doctor and even I do not save all my medical records, right? But they should be saved somewhere, someplace, right? So India, the National Health Stack, which is basically an initiative of Niti Aayog, has been trying to provide a digital health sandbox, sort of, to create digital health solutions along with the private sector. And they have really provided a lot of bandwidth to move in these areas. And now, because I did mention National Health Stack, I should mention what is NDHM as well. So NDHM was recently announced. It looks like a silver lining, of course, because it has a lot of tropes of, being open to decision. So one of the biggest problems in a country like India with 1.3 billion population and growing each day is basically discourse. We do not have active discourse with stakeholders while policy making, because most of the people that we, because there are so many people to interact with to basically distill the findings down into one single policy is oftentimes difficult, if not a mammoth task in itself. Anyway, so what NDHM is trying to do is build ecosystems from central government bodies, hospitals, labs, TPAs as we spoke about, but also health tech, which is again amalgamation of Indian Ayurveda, Unani, and other medications. Other, other healthcare practitioners, non-profit organizations, associations of people in these organizations, regulators, program managers, and state governments as well. So this is a good thing. We are able to now enter into discourses. There are already 4 white papers which have been published, and they are asking for citizen participation and citizen involvement, not just citizen participation but stakeholder involvement specifically. So the current problems, if we break down now, are that people don't have access to medical reports, right? People do not have know and have information about hospitals and doctors and labs. So all of this is about information disproportion, and in a big we do not have choice to consult the doctor remotely. In most cases, of course, there is telemedicine now, which we'll talk about in a second there. And people don't have easy supply of medication. So I have worked in centers in India in northern eastern UP, where a single medical tour is at least 2 days journey away, 2 days journey away, right? Doctors do not have, and what are the problems that doctors face? They don't have access to patients' medical records. Obviously, we have seen, soldiers suffer because of it, because EMR has not been implemented even in our defense systems. Our health records, even of our soldiers, have not been digitized yet. There is, treatment follow-ups are often missed because we don't even know how to track the patient, let alone, instruct and advise treatments and follow-ups. And doctors don't have ability to remotely consult the patient, as I just mentioned. Doctors and hospitals do not have ease of doing business, right? Ease of doing business has been somewhat of a talking point in India lately, but unfortunately, we do not have the exact same. Now, let me just breeze about to a couple of things that we are doing right. Right now, we are going, at least we are going hard on digitizing current medical records. We are building solutions like eSanjeevani, which are integrated solutions for healthcare, which are actually a very, very sophisticated portal. We are using now AI-based healthcare systems. So there is a new portal called India AI, which is promoting AI in drug discovery, in improving speed of accuracy and diagnosis, and of course EHR and digitization. Learning from robotic surgery and other areas, and also in clinical trials and drug. We are now looking at IoT systems, right? What are the so IoT has been a term which has been around for what, good 10 years. What we are talking about here is we are decentralizing healthcare. We are breaking it down to its uh, small parts and making sure that exact healthcare is at PSC level or even at your home care level. So we are building network devices which can test you for everything from a kidney function test to your liver function to your pap smear to your complete blood count, only through devices which either reach to you directly or reach to you via the frontline health worker network, which is Ashas, Enam, Anganwadi workers, and making repository, rich repository of this data, which is now the NCD cell. We are also looking at building systems for automated diagnosis. We already have amazing private entities which are doing great work in digitally diagnosing radiological radiological pictures. That could be a CT scan, that could be a HRCT, that could be X-ray. So we are seeing technology which is doing great work in this. We have now a different module which is now being very interestingly deployed in these systems. We have AI systems that can diagnose cataract as well as tell you which kind of what is the power. So basically, what is your myopic and myopic index, just through a photo on your phone, which is amazing, right? As well as we right now have AI which can diagnose even a pap smear, or look at gradations of cancer with higher accuracy than an oncologist, most cases, or an oncopathologist, which is saying something because those people are really skilled. So basically, we are creating health ATMs, which is with remote patient care, which reach distant areas, which are not asset heavy, where diagnosis is quick as well as primary in nature. And we are trying to bring down the cost of care drastically so that there is a stickiness. People can access healthcare aggressively and without I have seen people who have had limb amputations in tertiary care centers just because they were daily wage laborers and they did not want or did not cannot afford could not have afforded to lose their wages to go and show to a doctor when there was a small gangrenous occurrence in their limb. So we are trying to change exactly that. So what are the new trends in health industry? We have mobile health, we have 3D printing that is doing great work, and these are a lot of stakeholders that my I have interacted with both in my work with the government as well as my crazy passion in healthcare and health tech specifically. So we have analytics, which is doing great work. We have information technology, which is building networks for specified health needs. We have cloud computing, which is now being used specifically for health data storage, and of course, blockchain, which is helping in protecting the data in the best possible way. Of course, we have a great future for healthcare. We just need to make sure that the vision is very clear. It is about one thing: better health outcomes for everyone, better health outcomes for the society. And I think technology is a great equalizer, as we have always heard, and that can give us the leapfrog moment in healthcare technology to go towards better outcomes in a much faster manner. Thank you so much. I would want to take a couple of questions, if any.
Thanks very much, Sabine. I think there are a lot of things that I'd like to pick up on with that. So I guess when you started, you talked about some of the hard realities, that while there are technologies to prevent and treat a lot of diseases and disabilities that we overcome quite readily in the developed world, that there are parts of the world where this just where there are still um, rates of mortality much too high, or people that are unable to get treatment at a low enough cost for to be able to access it. So I think the aspect when we're in technology, we often think about technology is part of the solution, but there needs to be a combination of the people, the process, and the technology. And some of the things that you mentioned about medical errors, about some technologies that are available at hospitals, but people are many people are a long way away from a hospital and can't access it. That there is an aspect of process, and also deploying technologies, low cost technologies locally, um, where at the point of need, that will help to overcome those problems. And you mentioned Internet of Things, and I guess we're familiar with these sorts of devices, but to be effective, they need to be low cost devices that can be deployed at the edge, and
Yes.
then there needs to be a mechanism to bring data back to a point where it can be can be accessed and compared
No,
with other
John,
data.
I see there are mechanisms in place. Yes, technical solutions are there in place. You have
Mm,
API integration to
mm,
National Digital Health Mission, which is again the National Digital Health Platform,
yeah.
and a lot of these devices are API sufficient, or they
Mm,
have Bluetooth connections which can transfer data in effect. So there are networks and technology solutions in place. It's all about the will to put it into place and understanding the system at large, the need of the system at large. So I always believe that need comes before solution, and it always
mhm.
should. The assessment of need should always come before determining solutions. Unfortunately, many times we skip that phase of assessing the need and the bigger picture in detail before we start suggesting solutions for a region, which is why I feel a lot of programs and a lot of investment in health systems have failed repeatedly, because we look at the technology solutions, but we don't look at whether that fits the need of the hour.
Mm. So what you're talking about is having the flexibility to enable people who are close to the problem to be able to solve it with the most appropriate techniques, whether that's a technical solution or a people solution. So, and I guess what you mentioned about the ecosystem is that while government can provide some foundations like the national health stack,
Mhm.
that it's unreasonable to expect the government, any government, to solve all the problems, because the closer, the further away you are from the center, the less perspective you have of the problems at the point of need.
That is
So
true.
so
John,
where do you see the sort of partners coming in
may
to
I
play?
interject 1 second? So I
Mm,
think, so I agree with you actually. There's no need for interjection, but I think I
mm,
completely agree with you that government can be a trendsetter, in the sense they can define the regulatory needs to be able to understand the problem statement, but solution should come from technological validation and financial validation of the technological solution in any case. So if you look at, so I have been a huge advocate per se of insurance, right? Now insurance has always been looked upon from a very negatory or a predatory perspective, but if you look at the actual financial structure of the country, or rather structure of any health system, insurance systems as a society are the only ones that are financially aligned to better health outcomes. Neither your doctor, nor your hospital, nor your lab is going to be financially aligned towards your better health outcome, but your insurance is. Right?
mm,
So, why not use it as a value system to create preventive structures? And this has been successfully done in Sweden and Norway. These two countries have successfully implemented value based insurances at national scale and succeeded in creating huge profit margins as well for the insurance and the insurers, because none of them have to spend them. So that is what
mm.
we are talking about. We are talking about intelligent systems that are also fiscally beneficial for the right stakeholders.
Yes, and well, to that point, the well, so what is the environment that's going to help people gain access to insurance? Because this is another one of the issues that we often address when we talk about financial services is access to financial services, and banking is one part of it. Insurance is another. So, in terms of how to get people access to a range of financial services, including insurance. Where where do you see the partners taking a role
So
in
I
that?
think that is where I see huge, I hope that there is huge support from governments across the world, and especially in India, to increase the percentage of insured, right? Of course, they have tried with the Ayushman Bharat mission, sorry, which is the PM Jan Arogya Yojana, which is basically an integration of all insurance programs, both government as well as private sector. But I would want to propagate that more, because again, they are also stuck at around 14% of insurance across the board. We and Why this is a problem is because at that point, most insurances find it cheaper to sell insurance than to optimize the value of the insurance, right?
Mm-hmm.
So that is where I see the government becoming a huge stakeholder in the solution and pushing the idea and the solution around, or rather, helping people understand that insurance is good for you, that is going to protect you, and that is going to help you be fitter, healthier, and not just you. Establish referral networks which are going to be helpful in creating access. Today, more than 11 more than sorry 41% of all specialists exist only in 4 cities of the country. 4 cities, that's it,
Mm.
right? And if you look at all cities, we have more than 97% of specialties. There are no specialist doctors, not even a gynecologist in rural centers, right? So
Mm.
only with insurance and enforcing value-based insurance can we kind of move towards a solution where we go from primary to secondary to tertiary and not primary to tertiary health and occupy. Because, for example, we have only 3,000 electrocardiologists in the country, only 3,000. They are the only people who can put in a pacemaker, right? Or even,
Mm.
diagnose you for one. And if you have a chest and if you go directly to an electrocardiologist, then you are depriving others who desperately might need it.
Hmm. So I guess your point then is that insurance helps provide the financial incentive to solve the technical and distribution and
Yes,
delivery problems, because that will focus people's attention on the things that are going to
definitely.
demonstrate the value. Okay, that's a great perspective. All right. All right. Well,
My Before I quit, I just wanted to have one last statement.
yeah.
So, we need to have financial programs which benefit health systems through tech integration. So, technology is going to be a key in establishing healthy financial and health ecosystems, and that is what we need to focus on to build that relationship between the financial systems as well as the technology systems to optimize the result from health systems and delivery service systems. So I think that is the best possible outcome if we can achieve it. And that's where we thrive, of course.
Thank you very much, Sabine. And we have
Thank
other
you.
sessions later today on the healthcare imperative. So we this has been a great start to our conference to help us all to think through the macro as a problem challenge, as well as the micro level where we may be able to make an impact. So thank you very much for sharing that with us.
Thank you. Thank you so much, John, for having me.